Hi everyone, my name is Rakesh Popat and I'm a haematologist based at University College Hospital in London in the UK. And I'm going to be discussing a little bit about my clinical experience with belantamab mafodotin and focus a little bit about managing the ocular toxicity that we observe with belantamab mafodotin. So you may be aware that belantamab mafodotin is an antibody drug conjugate that targets BCMA or B cell maturation antigen, and recently has been approved in a number of different countries, either in combination with bortezomib and dexamethasone or with pomalidomide and dexamethasone for patients with relapsed or refractory multiple myeloma. And certainly this brings together a brand new modality of treatment for our patients and an important one that we should be considering for all of our patients who enter into the second line or first relapse space. So the question that we often get asked now is what sort of patients should we be considering for this? And really, I think we can be quite broad in terms of thinking about the patients who would be suitable for this. The key aspect is that this treatment targets BCMA, and currently outside of cilta-cel, we have no other BCMA targeted therapies available that's second line. And if you think about where patients are receiving their first line treatment, well, essentially they are being exposed to a CD38 antibody, whether it's daratumumab or isatuximab, which may be either fixed duration or continuous therapy. Indeed, they're also receiving lenalidomide, which is typically continuous therapy. And so patients entering into the second line space are normally lenalidomide refractory and CD38 exposed, if not refractory. And hence switching to a BCMA target makes a lot of sense. And I think that any patient entering into the second line area is worthy of consideration of one of these two combinations. Now, of course, people often ask about sequencing in terms of BCMA, and I think the data is very varied, particularly when it comes to belantamab mafodotin, about the impact of prior ADC use onto other subsequent BCMA therapies. So we always do recommend that you use the best treatment first, and given that belantamab mafodotin with bortezomib and dexamethasone gives a progression-free survival of approximately 3 years, that is currently one of the best treatments that we have available as second line. The IMWG, however, does recommend that if you are considering CAR T-cell therapy for patients, then that should be given ahead compared to any other treatment because of the potential detriment that can occur and because of how expensive and how difficult this treatment can be delivered on a practical level. But of course, most patients cannot access CAR T-cells, and so I think belantamab mafodotin is very effective in this. We do expect the majority of patients to have ocular toxicities. And whilst this is reported quite frequently, you must remember that this is normally a transient symptom that patients have. So typically patients will receive the drug and then will have or experience blurring of vision or maybe grittiness in their eyes approximately 3 weeks or maybe 2 weeks after the infusion, and it will last about 7 to 10 days before it improves. And so it's not that the patient is forever experiencing blurring of vision, it's a transient phase that the patient goes through after having the drug. And what's very important is that the patient is able to recover sufficiently before giving another dose of belantamab mafodotin. And that's why ocular or eye assessments are recommended before the first 4 infusions, so you can really kind of understand the impact of the drug onto the patient's eyes. Once you're through those first 4 infusions, then really you can base your dosing strategies according to the patient. So you ask the patient, do you have any blurring of vision? Do you have any grittiness in their eyes? Do you have any problems watching television, reading, or potentially driving? And then you base that decision as to whether you treat your patient on the answers that you get or not. And basically, if your patient has symptoms, then you should hold the drug. If your patient doesn't have symptoms in the last few days, then you can go ahead and give the patient the next dose. And that's the main way that we mitigate the eye toxicity with belantamab, is that we interrupt the dosing and wait until recovery and then repeat dosing. In terms of the schedule of dosing, well, whilst the license is to give belantamab every 3 weeks with bortezomib and dexamethasone, that typically is not feasible. When you look at the DREAM7 data, patients were receiving the drug anywhere between 3 to 12 weekly. And so in my practice, I will give it somewhere between 4 to 8 weekly, depending on how aggressive the myeloma is. So if you pick up the patient earlier on in the treatment pathway and doesn't have an aggressive relapse, then dosing every 8 weeks is acceptable. If you have more of an aggressive pathway, then dosing maybe every 4 weeks would be suitable. I do recommend that you start at the 2.5 milligram dose, really just to overcome any soluble BCMA, which could be acting as a sink for the drug, and you can get on top of the disease that way. And then I would dose reduce immediately to 1.9 milligrams thereafter for subsequent dosing. And then if you have further eye toxicity, then you lengthen your dosing out to 8 weeks and to 12 weeks. And then if required, you can reduce your dose to 1.4. And when you do this, then you effectively keep your patient on treatment for as long as possible, as opposed to having to stop for long periods of time. And again, when you look at the data from all of the DREAM studies collectively, it's very clear that interrupting belantamab dosing does not have a negative impact on the efficacy of the drug. It appears that the drug lasts for quite a long time, and this may be due to the multimodal mechanism of action. And so it is reassuring for patients that you can interrupt the dose to allow eye recovery without any detriment to their efficacy. Indeed, I think if your patient does have progressive disease, it's because they were progressing to the drug as opposed to the interruption of treatment that we see. So in effect, my recommendation to clinicians is that this is overall a very effective treatment and a treatment of choice for patients, whether they're young or older, particularly for those older patients who are being treated with a DRD. It's a highly effective treatment for them, particularly in combination with a proteasome inhibitor, which they may not have seen before. I think it's important to space out the doses of belantamab right from the start to ensure that you're not getting severe toxicity, which leads to long-term treatment interruptions. If you space that dosing out, then you allow the recovery of the corneal membrane to allow subsequent dosing to occur. And again, interrupting the dose does not have a detrimental effect. There's very clear data that shows that patients maintain their response despite having a dose interruption. And once you've achieved a good response, then space the treatment out to one dose every 3 months or 4 months. I have some patients who have one dose every 6 months, and they are maintaining a good remission for a long period of time. Thank you very much for listening, and I hope that that's helpful.